understand heterogeneity in disease, nor at times have we accepted heterogeneity in disease as well as we should have. And so in some ways, we've tried to design treatment systems which consider and develop everything around the average patient. And in doing so, like Vishal was saying earlier, we are practicing 18th or 19th century medicine, which was developed for the average patient because we were creating medicine to help get rid of infectious disease. Infectious disease, which was something which we were trying to address through a public health sort of philosophy. And we've continued to use that in the way we think about treatment. Average patient focused without truly understanding heterogeneity, without truly understanding how should treatment protocols be customized to every patient. And this was in some ways a deficiency that was coming out of the way clinical trials and the way pharmaceutical development has been happening in the last so many years, except perhaps the last decade, where we've started making some advances, some more thoughtful recognition of this. So that's the starting point. What this does is the following. Human beings across the world, we don't have a good ability to understand randomness. We understand averages, but the idea of what standard deviation is, what variance is, an abstract concept. And as a result, those of us who have training in clinical medicine, biostatistics, things like that, understand what it means to say, here is the confidence interval, here is the standard deviation in the results outcome. But for anyone else, they can only think of in terms of averages. What that does is, you design treatment based on a clinical trial, where you say, yes, I'm measuring on an average, and I'm ensuring that the standard deviation around that average is not too high. As a result, this treatment is effective or efficacious for the entire population that I'm looking at. Now, from a patient standpoint, they don't get the idea that, oh, there is some variance, it is still falling within the accepted, but maybe I'm outside. So if they're going to seek treatment for a chronic condition, and they find out they are not responding as well, their faith in that treatment disappears very quickly. And that's the leading reason why for chronic care, we see lack of trust in Western-style medicine. And not just in India, we see this across the world. Globally, when people have a chronic condition, they try out with modern medicine, and they say, oh, this is not working for me. And they oftentimes switch to alternative systems of medicine. So in order to change that, we are now embarking on personalized medicine, which explicitly recognizes this, and in some ways is going to bring more people who currently seek chronic care in alternative systems back into what I call as modern Western medicine. So personalized medicine in some ways celebrates disease and genomic heterogeneity. There are many ways to think about it. I'm going to focus on the more clinically accepted version of personalized medicine, which is, in the past, we used to think that one size will fit all, which means we would take a large patient population, design a medicine or a treatment or even diagnosis methods for them, and say if it works on an average with certain deviation around it, we'll consider acceptable. Now we are moving to a structure where essentially we try and recognize the differences in the genomic profiles of patients. And if somebody has a genomic profile that allows better response to certain treatment types, then they will only get those treatment types. Others will get a different treatment type. So the idea is very simple. It's not very difficult to understand, because we all intrinsically know that every one of us is different in some way. And only thing that has happened is medicine is starting to recognize the differences we have. And one way we started doing this is we're now having what are called as companion diagnostics. So drug development used to be, you have to show that for all patients who have this condition, this drug is efficacious. Now we are saying, well, it doesn't necessarily need to be efficacious for the entire population group, but if we have a companion diagnostic which allows us to say, for this subgroup of the patient population, this drug is effective, then we can get regulatory approval, in fact, much quicker than we could, and in some ways also cheaper, because we don't have to do very large-scale trial design. So in some ways, it has the potential of reducing the cost of pharmaceutical development if we do this right and thoughtfully. It has the potential of bringing more people into seeking chronic care in modern style medical systems. And it has the ability to target to increase efficacy and treatment outcomes. So in some ways, it is an area which can help all parties concerned, including the payers, the regulators, the healthcare delivery people, and the life sciences company, to win from implementing something like this. What I see happening in my observations of personalized medicine and how hospitals are responding, or the kinds of things that are happening with hospitals, is that traditionally we used to see that the interface between a hospital and a lab was what you see on the left of the slide. So essentially it was like a bow tie, where the interface point was very small, and it used to be someone in the hospital, not always the clinician, someone in the hospital who has the function of interfacing with the laboratory. And what personalized medicine is doing, in at least those hospital systems which are implementing personalized medicine in a full-fledged way, is that that interface is becoming wider. So many people in the lab are now starting to interact with many more people in the hospital, including multiple levels of clinicians. So if you're thinking about a large referral hospital, then multiple people in that referral hospital now will have an interface point with the lab. And so what this is doing is, in the past, we used to think about whether a hospital should have an in-house lab or should it outsource laboratory services to a third-party provider. And I worked with some hospital systems in evaluating that business case for them. When we would do the make-buy economics, we would always come up with the answer that it is better to let a third-party laboratory service provider run the lab, because the economics were favorable. There were large economies of scale in running laboratory services. Now what is happening is that the number of transactions, and when you think about make-buy decisions, oftentimes they're driven by what in theory is called transaction cost economics, which means if you have only a few transactions, and each transaction doesn't cost that much, then you are better off outsourcing, because then you leverage the economies of scale that come from an outsourced provider. However, if the transaction cost is high, or the number of transactions are very many, then the economics reverses. So what's starting to happen here is that it's no more the case that someone in a hospital can send a request to a laboratory and get one set of results back. That was a small 1 or 2 transactions. Now we're talking about hundreds of transactions happening between clinicians and laboratory. And each transaction is expensive, unless technology can drastically reduce the cost of this transaction to a level that we can perhaps then go back to that model. But at this point, that's not the case. It's a new field. Yes, technology exists, but because it's a new field, the cost of every transaction that's happening between a clinician and a lab is at this point high. As a result, if you redo the case for make-buy decisions for laboratory services in a hospital that has personalized medicine, at least in some therapeutic areas, you quickly realize that that decision changes. Many hospital networks are thinking about laboratory networks in-house, either with equity ownership, in some cases full ownership, in some cases other kinds of partnership structures. So it's no more sufficient to say we are a hospital network, we have selected our preferred laboratory network, and we'll work with them. If you're doing personalized medicine, you will need to think about a partnership model which is more involved than just the simple contract with them. Also, we've seen that in many emerging markets, the lab networks have been very fragmented, right? And then we're starting to see a gradual consolidation happening. So that's one direction the market is going. But the other thing that we're seeing in parallel to that, which is happening at least in some hospitals which are doing personalized medicine, is the consolidation is not so much happening in the lab network market. The consolidation is happening because large medical centers are bringing in laboratories in-house. So another trend which we are starting to see in some cases, I have a few examples here which I've learned about in talking to a few of the larger hospitals here in India who are at least embarking on a journey like this, or are starting to think more actively about this. The other interesting thing, and the reason I talk about personalized medicine in emerging markets is a lot of people, when I talk about this, a lot of people say, oh, this is very futuristic. This may happen in the academic medical center at the University of Michigan or other places, but this is not something we're seeing or we're likely to see in emerging markets anytime soon. I want to say that's actually, the converse of that is more likely to happen. The reason is simple. What is happening in OECD markets, including the US, or to a larger extent in Europe, is that the payers, whether it's a private insurer or it's a public payer, they are very slow at understanding personalized medicine. Because they are slow in understanding it, the reimbursement systems are not able to keep pace with the pace at which we are developing personalized treatments or the pace at which we are developing companion diagnostics and treatment combos. As a result, coverage remains poor. Reimbursement coverage remains poor. And if you think of an average patient in an OECD market, if you ask them to pay out of pocket, that's not something they're used to, right? Very few people in an OECD country will actually go to a hospital and say, oh, I have to pay for this diagnosis and this treatment out of pocket because it's personalized for me, because my insurer or my payer doesn't cover personalized medicine. We're less likely to see that. As a result, the uptake of personalized medicine, and especially companion diagnostics, is occurring, but not at a pace that we would like to see. Because the burden of proof in some ways is very high. Our payers are saying, oh, show me what is the net benefit for me as United Healthcare Group. And developing that proof for United Healthcare Group is quite onerous task. But convincing a patient that this is beneficial for you is actually easy. Personalized medicine is a very strong case for the individual patient. So, because India and other emerging market health systems like India have such a high degree of out-of-pocket healthcare payment, it in some ways puts India ahead of many other countries to be the vanguard of personalized medicine. The reason is, if I am a patient paying out of pocket, and you tell me you'll have to pay a slight premium, and I hate to put numbers here on what that premium will be, but if you ask me, you have to pay a slight premium, but we'll give you personalized medicine, which means that will look at your exact genomic structure and be able to customize therapy for you. I'm more likely to pay myself for that if it's a 10-20% premium. As a result, we can see a much faster uptake for companion diagnostics, personalized medicine, and drug diagnostic combos in India, especially in larger cities and in upper tier hospitals and medical facilities. That's not happening yet, except for a few instances where, very publicly known instances where one or two hospital systems are doing this. Apart from that, we're not seeing that. So what prevents that? In some ways, it's an information deficit. It's not so much that there is a structural barrier to the higher adoption or use of personalized medicine. It's more about people are saying, oh, this is meant for more developed, more mature health systems. It is not meant for us. We have other problems to deal with. The second is, oh, this is meant for oncology. This is not meant for anything else. This is just as futuristic cancer people who are thinking about personalized medicine. So both of those are myths. The first is, it is more suited to systems which have out-of-pocket payment, like I said. Second, it's not meant for oncology, even though the first entrance we saw in oncology, and that had to do with reimbursement systems. The promise of personalized medicines was not limited to oncology. It was because payment systems were easiest to make the case in the case of oncology. That's why we see early signs of its use in oncology. So my case here is there is a use of personalized medicine in countries like India. We are also seeing something very interesting, which is countries which have the ability, in some ways, to have good scientific talent and technology, because these are two things that you need to carry out effective personalized medicine. They can benefit because there are patients in lots of emerging markets who do not want to continue to be treated as an average patient. They want to get customized therapy. Their country does not have either the IT or the scientific talent of geneticists who are required to do personalized medicine. And if there is a country which you have a good presence of both of these, which is strong technical workforce in genetics, strong technology workforce, that will become a place where personalized medicine-driven medical tourism is likely to rise. And depending on which consulting firm you believe in, these numbers might be different, but people are projecting that the personalized medicine-driven medical tourism market, so this is not the medical tourism market as a whole, but just the personalized medicine-driven medical tourism market could be as big as $20 billion by 2025. So there are people in the Middle East, there are people in Africa, there are people in Latin America who are wanting to get personalized medicine in a place where they see good talent, good technology, and it's an opportunity that I believe we can leverage very well in India. I haven't seen a lot happening in this, but that's the reason I want to share this with you. The last thing I want to mention about personalized medicine is I've observed a lot of clinicians use technology, and I've also observed that the value proposition for a clinician to use technology is very limited. If I'm an overwhelmed clinician, unless you really make the case that this is going to make my life easy, simple, or my patient is going to value me more, I have no incentive to use technology. And that's the reason, despite 3 decades of investments in, we will do electronic records, we will help clinicians with decision support systems, we haven't seen much happen in terms of clinicians' use of technology. But personalized medicine can change that. And the reason it can change that, and it's already changing, I see some of my colleagues in the hospital system using more decision support tools right now, is because personalized medicine gets us to a point where we start hitting the limits of human cognition very quickly. Because a clinician who may otherwise be able to make a very good decision about what treatment to recommend now certainly realizes that, oh, you are sending me the genomic profile, you are sending me medical history, you're sending me pharmacokinetics and what they've taken as pharmaceuticals in the past. And now I have to combine these 3 streams of data, and perhaps you may also have some other things coming, like the Internet of Things and other devices and things like that. And now I have to combine all that, and from a list of hundreds of therapy options, I have to pick the right one for them. And if I don't pick the right one, I'm making an unhappy patient. Also, my payer is going to be unhappy and say, you didn't pick the right customized therapy. So now clinicians are saying, oh, this decision support tool, I need this. Because without this on my iPad, I actually cannot decide what therapy to choose for my patient. So what this is enabling us to do is decision support, where it is about cognitive abilities, is making a clinician start thinking about technology and becoming more receptive to the idea of technology playing a role in their practice, in their clinic, in their medical room. And we can, in the garb of that decision support, add many other functions, which is not going to be the driving force of why they use technology. But because they need this decision support, you can build little other things around it, and therefore the rate of adoption of technology amongst clinicians can go up. So this is one area where I think if you work on health IT and you think about this issue, why don't clinicians use all these fantastic tools that we've been developing, this is an area to change that. Push the limits of their cognitive ability and say, you cannot do this unless you run this analytics tool, because your brain cannot process it. It is so much information to process. So that's sort of the case. We're also seeing some other interesting, so apart from the things that were mentioned earlier, I think one of the other areas of data input that are coming in are about emotional health. And I have colleagues who essentially look at speech patterns and other proxies and indicators, and I advise 2 companies which work on this, are able to integrate what is your emotional status objectively, not by asking you a question, are you feeling good today or not, but by taking some proxies and some cues from your speech, from some other signals through recorded sensors and devices, and integrating that into the electronic health record. And that is enabling them to add something about the genetic profile, something about their emotional state, hopefully if all the sensors that the speaker before me was talking about, then we'll know their nutritional state, or we'll know their general health. And then the other thing which is happening is groups like Patients Like Me, which were essentially social networking platforms. Right? Their idea was, if I'm a patient, I go to a doctor for a condition, instead of just searching passively on what my condition is, or receiving information from a physician about what treatment options are best, I should be able to connect with people like me. And therefore the name was Patients Like Me. There must be someone who has my job, because I believe as an investment banker I have a certain kind of stress, and that means my disease condition is separate from everybody else's. So if I can connect on Patients Like Me with someone who has my same age, same ethnicity, same profession, almost same condition, then I'll ask them, how are you responding to this treatment? And that will help me become more informed user of healthcare and also of treatment options. So until now, Patients Like Me, or there are many other sites like that. They're essentially based on social network. Now people are thinking about, well, if you have low-cost genome sequencing, if you have personalized medicine, and if you have social networking platforms like Patients Like Me, you combine all of them. As a patient, somebody will now say, oh, I'm going to do a lookup on someone with my genome sequence profile, with my social network, ethnicity, other things profile, and then I will see what are they getting, how are they responding. So patients will become quite informed about the customized therapy which is best for them. And that's what is in some ways concerning clinicians, that if I don't respond to this now, if I don't have the tool on my tablet, I won't be able to respond to the patient's questions, because they are going to come prepared with all this Patients Like Me plus genome data. So that's how the field is at this point. We also have to, I also want to say, we don't want to overstress this. I mean, there is a chance we might take this to a level by a lot of marketing, promotion, patient awareness, where everyone who will come to a physician's office will say, I want personalized medicine. I want customized therapy, whether it is for something which is as simple as indigestion, or something where we don't even see that biomarkers differentiate what kind of treatment you can give. So I think the field is at a point where oncology, cardiovascular health, neonatal health, certainly immunology and transplant areas, and some areas of infectious diseases. Those are areas where science has advanced far long enough. There is a vast market waiting. There is a tremendous opportunity. There are a few clear value propositions, not all laid out in a way that you can take it and implement tomorrow, but there are some interesting value propositions. And someone needs to, in some ways, leverage all of these and create a model that essentially makes good use of where science has brought us, which can be good for the patient, can be good for the clinician, and will certainly be good for the payer. So I want to stop there. If there are questions, comments, critique, I'd love to hear that. Thank you.
A very interesting observation is that while we as a society are moving away from the traditional systems of medicine like Ayurveda and homeopathy, and we're going to the modern systems of medicine, but Ayurveda and homeopathy, I know, are very highly personalized systems of medicines, and we're moving away from that, really. So we are really going away from what you're saying in that sense.
So I think we have been going away, but we are coming back. That's how I'll frame it, which is, I think in the past, like I said earlier, I think we were arrogant in saying that Western medicine has figured out the right way to solve all disease conditions, while at the same time not acknowledging heterogeneity in genomics the way we know it today. So maybe other systems already had good things in place to acknowledge this, or the ways of understanding biomarkers were already in existence in some way, and the biomarkers were being used in customizing therapy. We don't know that because we don't have a lot of objective scientific evidence, at least in the way we like to see scientific evidence. But we are in modern medicine now in some ways going back and saying, no, we did it a little bit wrong by saying, oh, we have this one size fits all approach. So yeah, I would say maybe we were going back, now we are on the right track again.
We are.
One last question.
Yeah, Prashant, you were very impressed by the logic of the personalized medicine, as you explained, particularly in the OECD market. Now, it takes me to the thought. Yeah, sorry, my name is Prashant Yadav. I must say, not from medical health, but I'm deeply getting into it. I come from the FMCG corporate world. So coming back, now, it's very convincing from the OECD market point of view, where it takes me to the, let's say, developing markets like India. As I see the phase or maturity, if I may call it, of the clinical processes, or the world has a role to play. So it would be interesting if you reflect in terms of opportunity, market like this, from that perspective, if there is any thoughts, or did I get it wrong?
No, so I think I'm making the case that there is a huge and vast opportunity for personalized medicine in India. It may not exist at all tiers of the health system. So it may not exist at secondary care hospitals, smaller hospitals, but there is certainly a big opportunity at large referral hospitals. Because of out-of-pocket payment, primarily regulatory processes more geared towards personalized medicine. Perhaps even patient understanding, like you said, because of our traditional systems, patients may be more apt to thinking about personalized medicine. So all those factors are converging towards personalized medicine in India. Now, the challenge we face is it will require systems, and this is what I was trying to reflect in the systems between laboratories and hospitals, but also in-hospital systems, which will have to change and in many cases will have to be revamped to accommodate something which is going to be a slight shift in the way we think about treatment choice from a clinician standpoint. So yes, it will require some process changes within hospitals, but I think our larger hospitals are set up and quite equipped to make that change without large capital investment. So we're not talking about having to make very large capital investments to make that change. I think it's fairly marginal, and we can make that happen.
Thanks.
Thank you, Mr. Yadav.